Good evening, friends. I, Dr. Shankar Sharma, the governing body member of the API, is lucky enough and fortunate to introduce the giant of the API, the present national president of ours, Professor Dr. S. Arul Raj, who is MD, PhD, FRCP, Glasgow, FRCP, London, and lot many degrees with him. He doesn't wish to be known by these degrees, but what he is a man with very clear vision and with very great ideas, and he can tell you all the aspects of medicine. Currently, the present talk will be screening for silent CBD in diabetics, why and how. Everybody knows that the silent CBD is notorious in diabetics. 30% of the population of the CVD, which is present all over the world, and in majority in the diabetics, they are silent killers. Whenever chest pain comes to us, we always think in terms of CVD, but whenever a patient holding the chest comes with us, no pain, only perspiring, our first question is, are you a diabetic, non-diabetic or unknown diabetic? So here we start, and I hand over the talk to Dr. Arul Raj sir. So after the talk, we can have a lot many questions and answers to be solved. So over to Professor Arul Raj sir. Thank you.
Thank you very much, Dr. Shankar Sharma, for the nice introduction of me as well as the topic today. As said by Dr. Shankar Sharma, yes, coronary artery disease is often silent in diabetics. We know diabetes is huge in our country. Nearly 12% of the population have it. And we also know coronary artery disease also high in our population. And both of them have a very good linkages. I'll tell you the data. And but what we are going to discuss is about silent coronary artery disease. Patient says, I'm okay. He goes on, diabetic for 20 years, smoker. Whether he has a coronary artery disease or not, how to evaluate, why we should evaluate, what will be the best method. That's the essence of today's topic. This is the framework. Diabetes, as you all know, all of us know, 2 to 4 times increase in coronary artery disease, stroke, and peripheral vascular disease. The title of the topic is not coronary artery disease, cardiovascular disease. Cardiac disease and vascular disease. Wherever there is vascular system, diabetes always plays a major havoc. It can be a macrovascular, which usually cause an infarction or a stroke or a renal, or it can be microvascular, which causes the cardiac autonomic neuropathy or cardiomyopathy. The key causes are pathogenesis is atherosclerosis and vascular stiffness. And the factor which is responsible in diabetic people for the atherosclerosis and vascular stiffness, which goes to a macrovascular disease, is an insulin resistance, which all of us know. The Framingham cohort study, the incidence of CVD among diabetic men is twice, and women 3 times more common than in non-diabetic. We always know that women are protected in their, early life, that is before, closure of their, monthly, agenda. They are almost immune to coronary artery disease. But after, when they have a diabetes, whether it is before their cessation of their periods or after, they are more prone for coronary artery disease. This is the one that has been, described here. Secondly, the mortality in men with diabetes or without diabetes, there is not much of a difference here. With diabetes, it is about 54 deaths per 1,000. Without diabetes, about 50. But in women, there is a vast difference. With diabetes, women, the death rate is 46.7%. Whereas without diabetes, it is only 29.2%. And these are the asymptomatic coronary artery disease. These are a few data here. A coronary artery calcium is very much positive in South Asians. And a minimal block of coronary artery disease is much more common, 77%. A significant CAD is more than 50%, 41%. 2/3 to 3/4 of asymptomatic patients with diabetes have coronary artery disease. That is why we are here on this topic. If you go through that, there are no, cardiac changes. There is diabetes, hyperglycemia, insulin resistance comes. There is a subclinical diabetic cardiac disease, goes for atherosclerotic changes, and coronary microvascular dysfunction, cardiomyocyte changes, clinically manifests in the three major criteria as a coronary artery disease or a cardiomyopathy or a heart failure. This is the current, picture. In cardiovascular disease in patients with T2DM can always present with classical cardiovascular disease symptom and can be an angina, heart failure, an occlusive vascular disease, or dysrhythmia, or all are caused by vascular factors, or can be totally atypical symptom, what we call silent ischemia, silent myocardial dysfunction, cardiac dysrhythmia. Suddenly patient comes to you, you find an irregular rhythm, do an echo, EF is very low, and these are the classical symptoms are often recognized, whereas the atypical symptoms are not recognized very easily, and therefore adds to a high risk for cardiovascular event. These are the clinical presentations of a cardiovascular disease. Can be in the coronary artery, we know an ACS, acute myocardial infarction, hypertension, unstable angina, cardiomyopathy, a microvasculature goes for coronary, cardiac autonomic neuropathy, can be a stroke, a diabetic autonomic neuropathy, peripheral artery disease, and a renal, artery disease. These are the clinically the complications, vascular complications of diabetes, both on the microvascular side and the macrovascular side. And in the cardiac side, you have more incidence of hypertension. Always I used to say, diabetes always has very bad companions. You get into diabetes, get into hypertension, dyslipidemia, renal, cardiac, or cerebral. And nearly 30% in D1, TM, and 60% it is there. And the diabetic cardiomyopathy is about 20%. These are the clinical presentations of, the vascular disease in diabetic patient. Myocardial infarction is up to 40% in many countries. Silent CAD in patients without diabetes about 1 to 4%. With diabetes about 10 to 20%. We'll have to keep that in mind. The same way, the risk for heart failure is about 2.5 times more in men, whereas 5 times more in women. Microvascular disease, can present as heart failure in diabetes mellitus. Cerebrovascular disease can be an ischemic stroke or a hemorrhagic stroke. It is about 2.27, and then ischemic is about 1.56%. And there can be a microvascular disease with prefrontal lobe dysfunction like dementia and a presenile, Alzheimer's. And coming to the vascular disease, there is about 2-fold increase in the risk of lower limb ischemia. In earlier days, we have seen many gangrenes and amputations of the toe or the leg itself. Ankle brachial index is the clinical marker. When it is lower than 0.9, we consider there is a peripheral vascular ischemia. In the renal side, the renal, vascular occlusion is more common in about 10 to 30% of people. It can have a macrovascular or a microvascular, and it can be always detected by an ultrasound Doppler and MR or angio. A revascularization, either surgery or plasty, is possible. A cardiac autonomous neuropathy has increased mortality because of a dysregulation of the autonomic nervous system, and they can always present with the cardiovascular disease too. These are the various ways of approach to evaluation of silent coronary artery disease. For the research model, silent coronary artery disease, T2DM has been equated to coronary artery disease. We all physicians know. And even a myocardial infarction can be silent. I used to say a myocardial infarction can be silent in symptoms, silent in the ECG also. Can be there 4 hours, 6 hours, 12 hours. We need to. And the myocardial, when there is an objective evidence of myocardial vascular occlusion, you do an angio or do an evaluation, there is a objective evidence. But subjectively, it is not there. The chest discomforts and angina equivalents are not there. The objective evidences are, as I told you, ST segment or regional wall motion abnormalities or perfusion defects. These silent myocardial ischemia can be put into 3 categories. One is the least common, very rarely occurs here, and a completely asymptomatic patient. And the type 2 is in a previously coronary artery disease known. They can have further coronary artery disease or an extra block or an extra vessel block, but still it could be there. And the third is the most common that we see as an acute syndrome. These are the 3 types of it. There is an ICMR India study, there are about 7 million people have diabetes in India, and it is 77 million. It is expected to rise by 101 million by 2030. The incidence of SMI is about 10 to 20% in diabetic people and 1 to 4% only in non-diabetic people. And silent myocardial ischemia has been associated with, significant coronary stenosis and angiography on 35 to 70% of people. And the angina equivalence should not be, ignored. There was a study, rather the only study, the detection of ischemia in asymptomatic diabetes was there, and it has proved about 6.3 times it is more common in diabetic people. Now, clinically, what we have discussed can be summarized here. There is a coronary disease, type 2 diabetes is often silent and asymptomatic, but high incidence of MACE and permanent myocardial damage and scarring is there. Therefore, screening of diabetic patient is become for silent myocardial ischemia becomes a crucial role. What is the mechanism of here? Here is a coronary artery disease where due to endothelial dysfunction and microcirculation, and plaques are very common. They are always in diabetic people, unstable or vulnerable plaques. Therefore, and you may also think for every patient you have a neurological way of recognizing the pain. Why it is not there in diabetics? All of us know the autonomic neuropathy makes that the pain insensitive. There is also another mechanism that has been described in diabetic patients who have microvascular disease. As we said, they have presenile dementia or an Alzheimer's. Therefore, the pain impulses from the heart are subjected to neuronal processing. Therefore, the brain does not recognize even if there is a pain. There are some SMI mimics. We all know a hyperkalemia with a tall peaked T wave or a GI source or musculoskeletal. Often they are mistaken for a coronary disease. One, we miss it. Two, we mistake. And this is the recommendation of ADA. These are the following cases. The diabetes should be evaluated. Typical or atypical chest pain, abnormal ECG, or an occlusive arterial disease, peripheral or occlusive, or arterial. More than 35 years of a sedentary lifestyle in a patient who wants to have a vigorous exercise program. 2 or more risk factors in addition to diabetes like dyslipidemia, hypertension, tobacco use, family history, or a micro or macroalbuminuria. These are the subset of the diabetic people who should be subjected to an evaluation for silent coronary artery disease. These are the methodologies available here, and we'll just see that very briefly. This is an exercise test. What we used to call it is a treadmill test. Is the easiest, commonest method which is available to evaluate a silent, myocardial ischemia. But there is supply and demand, but there are people who are not able to walk, either due to pain or breathlessness or knee. Therefore, graded exercise tests are now available. We can always use that. The typical, finding is a ST segment depression, a flat depression of more than 1 millimeter is, classically, suggestive of it. And there is all patients with a stress test positive need not be subjected to coronary angiography. There are low risk, medium risk, and high risk. And the medium and high have to be, subjected to coronary angiography. There are other findings beyond an ST segment depression in treadmill to say that it could be a coronary disease. That is a treadmill exercise score by Duke is available here, and a heart rate recovery. See, always when you exercise, a patient heart rate goes up, but it has to recover back to normal. If the time duration is longer, you will have to always think that this patient will have a coronary artery disease. I used to teach earlier when TMT was a very favorite investigation. If the ST segment depression, which has come down, it should recover back to a normal place. If it is delayed, we can always think that it could be due to a severe coronary artery disease, most probably a left main, something like that. Ambulatory ECG monitoring can very well pick it up, but its sensitivity is high, but specificity is a bit low. And in echo, all of us know it's the best non-invasive method available today to us. And Even all physicians are able to do that. I'm so happy that it has become an extended form of a stethoscope. A regional wall motion abnormality and an ejection fraction always gives us more information. Sometimes the patient clinically, you still suspect resting echo is normal, go for a stress echo, either a dopamine or a dipyridamole, or you can do a stress on the table itself with a cycle wheel, but usually a dopamine, stress test is good. And a CT angiogram, we can always do that, very safe, and only thing is that radiation. There is an entity called as a cardiac fat, which can be an epicardial fat or a pericardial fat, which you can do that if you carefully do an echo. That always says that the patient has a, fat, that is an atherosclerotic plaque. It is very, very useful. These patients can be shortlisted. All of us know an MRI, a myocardial perfusion imaging, can always tell you where is the lesion, can always tell you how is the cardiac function too. And it's very safe and no damage to patients' body. But recently some nephrological fibrosis has been recorded. A thallium or nuclear stress test, when it is available, a SPECT or a PET scan always gives you the regional perfusion abnormalities. And of course, the cardiac catheterization and a coronary angio is a gold standard. All diabetic patients who have an ischemia on a stress test have to be, subjected to a coronary angiography. The advantage here is it is not only diagnostic, therapy can also be done. You can put in a stent, a PCA can always be done. And similarly, the vascular system in the brain, you can do an MRI. When you do an MRI, always ask for an MR angiography, so that you can always delineate the circula villis. All vessels could be well delineated. A magnetic resonance venography can also be of much use here, and a carotid artery screening can be done by a Doppler, and a carotid intima media thickness still holds good. When there is an intima and media thickness which is more, always says there is an atherosclerosis. And when there is an intracranial lesion, when you don't have any access to a CT or any major imaging, a simple TCD, transcranial Doppler, you can keep it here and try to assess the anterior cerebellar and middle cerebral. We'll be able to do that. The angle brachial index, all of us know. Arterial peripheral Doppler, fine. To summarize, on the functional test, the electrocardiogram has low sensitivity and specificity. All of us know can be normal. Next is the ECG, moderate sensitivity, but specificity is about 90%. A radionucleotide image, sensitivity, specificity is fine. And a stress echo is always highly, sensitive here. You can always do that. Coronary artery calcium has got an easiest way of, saying that patient has got a coronary artery disease. And you can always go for the question, why you want to screen? Do we want to identify that that is a coronary disease? And also we want to specifically scale up and say that this is the extent, single vessel, multi-vessel, or a left main, or an osteal lesion, or multiple lesions in a single vessel. We will be able to do that, so that you can plan a revascularization. If it is not possible, you can think about a drug alterations. That is the system. And when to screen. There are asymptomatic patient, normal ECG. Just take ECG, once in a year, and echocardiography also every 3 years. If there is a wall motion abnormality, immediately stress test, positive, coronary, negative, do that after every 2 to 3 years. In high-risk patient, immediately go for a stress test and you go for a coronary angiography. These are a few markers. Without these tests now, these few markers can tell you that this patient, that cannot tell the extent of it and the signs of it, but that can make the physician to think something like a simple erectile dysfunction, micro or macro, albuminuria, a retinal artery narrowing, carotid intima medial thickness, highly sensitive C-reactive protein and troponin T, and a microalbuminuria, copeptin, and a coronary artery calcium, and a cardiac fat. These are all very simple, non-invasive investigation which we can add up in our day-to-day practice, so that we can raise the suspicion of a coronary heart disease in a diabetic patient. These are the new markers which are being utilized. Wherever it is available, we can definitely use it. These are the new markers. Now the workup should be patients with symptoms, or they are coronary equivalent, do an ECG, equivocal, do a copeptin and your troponin. If it is negative, you can observe the patient and you can go home. If there is a positivity, immediately go for a stress test, or if it is a severe case, you can straight go for an angio. These are the summary for the evaluation of silent CVD. In a cardiac, you go for a biomarker, ECG, stress ECG, imaging, CT angio, nuclear, but ultimate is a coronary angiogram. When there is a microangiopathy, echo and a cardiac MRI. When you suspect a disease of the vascular system in the brain, can have as I told you, an MRA, MRV, carotid Doppler, transcranial Doppler, still a cerebral angio may be needed. There also we can try to, extract a thrombus which is there, or put in a stent and save the life. And there is a peripheral artery disease, ankle brachial index, arterial Doppler and angio. When there is a renal, you can always do a Doppler or an angio. You can try to medically or by plastivise, we can always try to correct it. Now, what is the best approach? This is what goes in the minds of all our colleagues. The most appropriate test and initial test of choice will be a treadmill exercise. A simple thing in a coronary artery calcium in a CT scan can always tell us. Stress echo and stress thallium are always reserved for patients who are not able to exercise. Coronary angiography is reserved for definite cases when the PCI will be needed. Thank you very much. Thank you so much.
Thank you very much, sir. Professor Arulaj. Now I request my friend Dr. Ramchandani to have some comments on this and invite questions and answers.
Thank you, Dr. M. Shankar Sharma. And first of all, I thanks to all the organizers for giving this opportunity to chair the very important session of our chairman, API, Dr. Arulaj sir, and Dean of ICP, Dr. Shashank Joshi sir. I think Dr. Arulaj sir has covered every aspect of the silent CVD in diabetic, why and where. They covered almost the day-to-day practical tips as well as the newer things. I think there is in chat box there is no any question, so I think if any question is there, we can discuss after both the sessions, sir. If you agree with this, so we can take the question after the lecture of Dr. Shashank Joshi sir.
Yes, sir.
Now,
No, Shashank is waiting for a long.
Dr. Arulaj sir, only
I
just
too love to listen.
I'll have just a
please,
small
please.
comment. The comment will be
Please.
that
Yeah,
we have
sir.
discussed all the aspects of the silent ischemia, how to approach the things, and what should be the take-home messages for the analysis. But one point which should be elaborated, that after all, why this is the problem? Why there is a silent ischemia, or why there is a silent infarction like this? Other than diabetic autonomic neuropathies, what else could be the causes? If you can just throw some light onto that.
Yeah. Okay. See, we are now going into the pathophysiology of vascular disease in diabetes. There is a very, very large system I need to go through. This, basically, there is an endothelial dysfunction. And there is an addition of a, fat level which is going inside the intima. When both of them work together, that goes on accumulating, a plaque goes. And the plaque is usually in diabetics a vulnerable plaque, and it ruptures and causes it. And the diabetes, when it is poorly controlled, insulin resistance goes on, and it causes a vascular, we call it as a stiffness, an arterial stiffness. An arterial stiffness, intimal changes, as well as this atherosclerotic plaques. That is why this happens. This is what, in short, I can put it to.
Thank you, sir.
Yes,
Thank you so much. So, Dr.
Thank you so
Ramchandani, if
much.
there are no questions, then we can take the second speaker.
Thank you.
Yes, sir. Definitely, sir. We will request our second speaker, Dr. Shashank Joshi, sir. If I request to So after completing the wonderful session by Dr. Anurag sir, President API, now we are moving to the next session, and the speaker is Professor Shashank Joshi. He's a Padam Shri, Dr. Shashank Joshi. I think Dr. Shashank Joshi does not require any introduction, but presently he is an endocrinologist in the Leelavati Hospital and Bhati Hospital, and he's a Dean of Indian College of Physicians and the President of Indian Academy of Diabetes and founder, Vice President of PCOS Society, and the chair of IDF Southeast Asian. There's a many accolades in his CV. So I request Dr. Shashank Joshi sir to kindly start his session on the very important topic in present era, that is COVID and hyperglycemia approach to management. He has a very wide experience for managing this COVID and in this last 9-10 months. So kindly share his experience also. Thank you, sir.
So thank you, Dr. Ramchandani. At the onset, I want to thank Dr. Arul Raj, Dr. Nihar Mehta, and the whole team of GCDC for keeping COVID and diabetes. And you know that we are in one of the most impactful and compelling reasons for death on people living with COVID has been diabetes. So I'm going to have 4 parts to my presentation. And the first part is how COVID-19 has impacted patients with diabetes. We know that when COVID has become pandemic, the morbidity and mortality of COVID has been driven, number 1 by diabetes, number 2 by obesity, number 3 by hypertension. So they are these big 3 killers with COVID, and that's where we all know. So what is the link between diabetes and COVID? First is we know that any diabetic patient is higher risk of microbial infections. Number 2, we know that diabetic patients have a higher pneumococcal risk and a higher risk of developing lower respiratory tract infections. And number 3 is any type 1 or type 2 diabetics has increased risk of serious infections, 6% increase in infection-related hospitalizations and 12% increase in infection-related deaths attributed to diabetes. So this data has come from China, it has come from US. Our publication will be out a couple of months from now, even from Mumbai. This is New York data, 56% hypertension, 41% obesity, diabetes 33.8%. Our Mumbai data, which is unpublished, is 55% hypertension, 50% diabetes. So that's how the pecking order is, right up there. So obviously, what are the associations? The first is that diabetic patients have increased risk of infection because they have innate immune defects. So they're linked to high glucose, both acute hyperglycemia and chronic hyperglycemia. Number 2 is diabetic patients have an exaggerated pro-inflammatory cytokine response. So they have a higher IL-1, IL-6, TNF alpha. Number 3 is that we know diabetic patients have increased expression of ACE2, and ACE2 is the putative receptor or the docking receptor for SARS-CoV-2 virus. And number 4, diabetic patients have a hypercoagulable state or increased coagulation activity. So these are the big 4. We all know that a docking receptor of SARS-CoV-2 is the ACE2 present in the lung, heart, kidney, enterocytes, and pancreas. And pancreas has been at the spotlight in COVID. And there's data to suggest that. So if you see, this is a Chinese paper published clearly showing that the most consistent finding between diabetes-related traits was the ACE2 expression. So when you do a GWAS on type 2 diabetic patients, you know that type 2 diabetes is causally linked to increased ACE2 expression. And that has led to really the challenges which we see with COVID today. And we also now know that all the proteins which are linked to altered ACE2 expression, they have challenges in the enriched pathways, as they call it, on cytokine to cytokine receptor interaction, VEGF signaling, JAK-STAT signaling. And therefore, the current drugs which are being investigated into the COVID diabetes links are the ones which may have a cytokine interaction interrupted or disrupted, a VEGF signaling interrupted, or JAK-STAT signaling interrupted, because we want to prevent a cytokine storm. So obviously, when the SARS-CoV-2 docks, it impairs neutrophil recruitment, it impairs interferon production from NK cells, it impairs the macrophage activity, it ensures that the antigen presentation by CD8 and CD4 T lymphocytes from the dendritic cells is poor, and there is excess of ACE2 expression. And that leads to a dysregulated immune response from the TH1 and TH17 cells, leading to a cascade of cytokine storm, which leads to an ARDS multi-organ failure. And obviously, the respiratory epithelium is mucotic, is necrosed, and there's a lot of vascular permeability leak. And that's what we see in SARS-CoV-2 in a cytokine storm. Obviously, we know that there's a new entity now called flat blush diabetes or sudden onset diabetes due to COVID. And clearly, we know that during the coronavirus infections, the islets of Langerhans have the functional angiotensin 2 receptors and they are destroyed, and you get new onset diabetes, including decay in that situation. Clear data linkage first coming from China and then later on rest of the world that the fatality rate, if it is 2% in diabetic patient, was 7%. Here you can see that simple glucose is the fifth variable in COVID care. That mere high glucose, and this is a US Boost Board study which clearly showed that 28.30, one-third people who have diabetes or high glucose will die compared to people with only 6% without diabetes. So there's a fourfold increased risk, and that's all linked to this ACE2 and angiotensin 1 and 2 pathway through basically the MAS receptor pathway, which is anti-inflammatory, anti-fibrotic. So there is actually a switch from anti-inflammatory, anti-fibrotic pathway to a pro-inflammatory, pro-fibrotic pathway. And this whole imbalance leads to overactivation of angiotensin 2 receptor activation. And clearly the Bruce Boden data clearly showed that simple high glucose incurs a 41% mortality in diabetics. So diabetes and COVID is a clear-cut demographic data to show that there is evidence base to show that. So there is metabolic inflammation because there's a predisposition to release cytokines. There is a cytokine possibility of storm because the inflammatory cytokines cause multi-organ failure. The wound healing is impaired in any diabetic, which we all know, because the immune system is compromised and there is impaired healing and prolonged recovery. And there's a dysregulated immune response. So there is aggravated lung and prolonged pathology. Also remember that diabetics have glycosylation of immunoglobulins. So the antibody responses are also poorer. IDF has said that it is a functional immunized compromised state, diabetes, and glucose promotes viral replication. So we have our own Indian risk score in which diabetes is right up there in the pecking order. So what are the challenges we face as physicians as priorities in people living with diabetes? And we all know this, that there is a lot of collateral damage in non-COVID care, and diabetes is right up there in the quality of care. And we know that we need to stay healthy and control diabetics during the pandemic. And clinical guide of management is going to be very easy. So we have a lot of recommendations for general practitioners, and all you need to do is diabetic patients need to take extra care. They need to do reverse isolation. They are a vulnerable group. They are a comorbidity group, and they need to stay healthy. And for outpatient care, we know that they can be teleconnected through telemedicine models. They need to not stop their drug therapy. They need to be connected with a healthcare provider, as simple as that. And try to maintain optimal glycemic control. Try to keep the time in range of glucose. And that's all we are asking for. And obviously, people living with diabetes, if they fall sick, they can get serious issues like diabetic ketoacidosis or hyperosmolar states. They might have higher need of insulin. They may get dehydrated, and they might have anti-insulin release of hormones. And therefore, we need to put them on spotlight for ASAP medical care. Preferably COVID patients with diabetics who are above 50, we prefer them to be hospitalized. Usually we continue the oral agents or injectable medications they are on, and we monitor the glucose more carefully. If they eat less, we monitor for hypoglycemia, and if they deteriorate, we need to move them to ICU care. So obviously this is the step-by-step approach for a diabetic patient with COVID infection. We need an aggressive approach. We need to put them on spotlight and hit hard, hit early, both for glucose and for COVID. So that's the dictum. And follow all the sick day rules. So hydrate, 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 and ensure that they have insulin on board. And if there is a doubt, just put them in the ICU. So good glycemic control is very critical. And therefore, when we do glycemic management of people living with diabetes with COVID, we need to stratify them and keep the euglycemic levels. So what are the treatment pathways, which we have for diabetic patients? We know that follow the sick day rules and monitor glucose more carefully. So sick day rules are there for any patient, and we know that never stop insulin, ensure the glucose is checked every 4 hours, drink adequate fluids, weigh yourself every day, check your temperature morning and evening, and ensure that you have adequate fluids. We ensure that there is no hypoglycemia, and we ensure that you are taken care of. So obviously there are a lot of guidelines in this process, and if there's a decay or hyperosmolar state, obviously we need to get aggressive. But there are two simple things which we need to know. One is when you manage people with diabetes with COVID, either you continue oral agents or give insulin. If the patient is in the hospital, inside ICU, it's insulin all the way. If they take steroids, it's insulin, insulin, insulin all the way. But a patient who's home isolated or with mild COVID, you can manage them very beautifully with oral agents alone. So obviously, a patient-centric approach with age, severity, comorbidities, hypoglycemia risk is the order of the hour. And we need to maintain euglycemia. We need to ensure there is no volume depletion. We sometimes have to stop a couple of agents. So the simple do's and don'ts are SGLT inhibitors can cause a lot of dehydration, stop them. Metformin, if you are in hospitalized situation, stop them. Secretagogues and insulin can cause hypoglycemia. So you need to have that care. That's what the ACE said us. And obviously, for ordinary cases, simple subcute insulins will do. If there are severe and critical cases, you need IV insulin drips and monitor euglycemic control. So clearly, we try to aim a simple approach, and we try to aim at euglycemic level and monitor for ketoacidosis. So we know that every agent has had a pro-COVID and anti-COVID role, like insulin. We know insulin reduces the renal ADAM7 expression in diabetic mice. It reduces the urinary ACE2 shedding. It increases the intrarenal ACE2 expression. But there's no human data to support it. So there's nothing to worry. Insulin is safe. It's good. Metformin might be anti-COVID. There are trials going on it. Sulfonylureas can cause hypoglycemia, otherwise no concern. Pioglitazone actually can upregulate ACE2, insulin-sensitive tissue in rats, and they can downregulate the ADAM17 in human skeletal muscles. So there is a theoretical risk of poor outcome. But when they did human studies on human pulmonary ACE2 expression, actually they found reverse, that Pio was protective. So we don't know the answer for Pio. Liraglutide initially was thought to have poor outcome. Now we know that it may be protective. Same thing with SGLT2. We said we avoid it because they cause dehydration. Now there is a trial going on of DAPA in United States protecting COVID. Probably the agents which have really now come up in the pecking order are gliptins. Gliptins can be anti-COVID because we know that MERS had DPP4 as a serine protease as a docking receptor like ACE2 for SARS-CoV-2. So that's probably the only agent which might have some data to suggest that they might be useful apart from metformin. Obviously, the front door entrance to any casualty with COVID and hyperglycemia means that stop, admit the patient, monitor the glucose, stop the SGLT2 inhibitors, and ensure that you treat them appropriately. Monitor fluid electrolytes and ensure that their insulin is given on board and ensure that it's handled well. So there is a very simple triaging system. UK uses this quite well, that look at shortness of breath. It could be a metabolic acidosis. Ensure that it's all measured well, measure the glucose and ketones, stop the SGLT2 inhibitors because they can also cause euglycemic ketoacidosis. Ensure that metformin is held up, review safety of ACE inhibitors and ARBs and NSAIDs if they are on board. And then based on the glucose values, treat aggressively with insulin drips with hydration. So that's really the advice to everybody. And inpatient care will need monitoring. Oral agents usually are held and insulin is the standard of care. And manage blood pressure and cardiac disease well. So that's very, very crucial to understand. There is no need to stop ACE or ARB inhibitors. A lot of controversy came in, but AHA and all the US and European associations said it's okay to give any of these ACE and ARBs. The only agent which has probably an anti-COVID role is probably DPP4 because we know that they are the entry receptors for ACE2. They were the key receptors for MERS-CoV. They are serine protease receptors and inhibited by gliptins. The structure homology is there between SARS-CoV-2 viral protease and DPP4 inhibitors, and it's anti-inflammatory, anti-fibrotic, and immunomodulatory. So probably in elderly diabetics and obesity, gliptins are the only agents, and sitagliptin has been shown very clearly that it can have some very good retrospective data from Lombardy and United States that it can be useful. And this is a mortality data showing that it can actually reduce mortality. So that's some data, but obviously this is all work in progress. So there are some novel mechanisms, and probably there is a likelihood that there could be an anti-COVID mechanism because we know that the membrane-bound DPP4 or CD26, if it is blocked, then there is a facilitation for coronavirus entry is blocked. So probably you could have a solution, and you can see here the soluble DPP4 or CD26. Actually, you can see the SARS-CoV-2 binding receptor is very closely there. With API and ICP, we came out with our own recommendations. Look at diabetes and obesity strictly, look at immune defects strictly, look at stress hyperglycemia strictly, and then there could be pancreatic damage. So if you have a male, elderly, hypertensive, diabetic, CKD, they need strict vigilance. Use diabetic-specific nutrition, diabetic-specific formulas efficiently. Insulin oral agents can be used and manage hypertension well. And we are in lockdown times, but of course we are partially open now. We're looking at different waves and we need to do telehealth. And in telehealth, it's all about remote communication and communication. So insulin titration, hypoglycemia, hyperglycemia can all be done remotely and by good efficient communication. Some parts you might need face-to-face, like type 1 diabetics need face-to-face. Somebody in A1C with more than 10% ketoacidosis needs face-to-face. You need to educate a patient, you need face-to-face. Otherwise, you can manage on video, telephone or email, or sometimes you may even defer an appointment. So we have to protect our patients and preserve ourselves is a new normal for managing chronic disease. And you need to do mass testing of COVID for diabetic patients. And we need to do telemedicine. Telemedicine has been very efficiently used. And obviously we need to do it ethically, appropriately and correctly. And we need to have a setup. And then of course, look at nutrition. Never forget nutrition. Have adequate water, have fruits and vegetables, balance your diet well, and ban all canned goods. Focus on nutrition, mental health and vaccination. That's something which we need to recognize very well. We have a lot of vaccines to be given in the COVID era, like flu vaccine, pneumococcal vaccine, typhoid vaccine, hepatitis B and zoster vaccine. So that's something which we need to recognize. So I'm going to summarize for brevity of time that diabetes is a risk factor for SARS-CoV-2, and it is you get more severe COVID. Glucose control matters and is important. We need to empower and educate our physicians, patients, and healthcare workers to manage diabetes well. And we can use telemedicine and technology as a part of the new normal. And despite the protection of diabetics, we should know when they need hospitalization. And holistic care of diabetic patients is needed. Thank you for a patient hearing.
Thank you, Shashank Joshi, sir. It was a very clear-cut approach, very sharp. We have read about the Coronado studies from the France, but I think you have just demonetized that. Now we don't need any Coronado studies and long-term studies, but what we have assembled from Mumbai will be Dr. Shashank Joshi's studies in COVID. And you have been one of the mentors in the COVID management right since March. I have been searching you and we have been talking on multiple occasions. You have helped us out in managing our centers over here in Bhagalpur and lot many all over India. Everybody is approaching you. And whenever one of our colleague as a doctor falls ill with COVID, we look for one person, and that is Dr. Shashank Joshi. I think Dr. Ramchandani will also help me out during this. So it was all take-home messages very well. I think if there are no questions, then I will ask Ramchandani to comment, please.
Thank you, Dr. M. Shankar, for your kind words. And you have been very active. And I think congratulations to you also that you have, and I congratulate all our COVID care doctors and all our medical fraternity for rising up to the occasion, because it has been a challenging time for all of us.
Sir, thank you, sir.
Definitely, Dr. M. Shankar Sharma, sir, I'm strong. I'm along with your comments about the management of COVID in this era, especially by Maharashtra and especially by Dr. Shashank Joshi, sir. We are also following their guidelines and their webcasts daily almost. And here we also managing the things according to Bombay approach. And definitely we have a lot of recovered very nicely with their protocol. And fortunately, we have controlled still now. Now we are lot of COVID is little bit controlled in our area, and very Dr. Shashank Joshi had not only helped to the our centers and your center, but also entire nation is helped by Dr. Shashank Joshi's approach. And government of Maharashtra also said that he is a true corona warrior. Thanks and congrats to Dr. Shashank Joshi, sir. And thank you for this wonderful presentation of COVID and hypoglycemia and clarifying the entire aspect from beginning to the last of the vaccine. Thank you, sir. Thank you very much, Dr. Shashank Joshi, sir.
Shashank Joshi, sir, I will be failing in my duty if I don't really say a very good thank you to you. I am a diabetic. I am on metformin and MRL, 1 milligram. I suffered from COVID. I just recovered yesterday only. My CT value went down to, this was 14 on second. And just I was never upset because I knew that there is at the hem of the affairs, there is Dr. Shashank Joshi. If I am in any trouble, I will ask him to help me out. So I was just managed, and just like Eklave looking at the Dronacharya faces, I just remembered you and I got cured. Thank you so much.
Take care, Dr. M.